Thank you for that introduction, Tom. Good afternoon, everyone, and welcome to the NPHI Public Policy Strategy and Agenda discussion. During this meeting, we would like to cover the following topics with you all. First, an outlook on the 2020 elections and their impact on NPHI's public policy and advocacy strategy. We would also like to review the key 2020 policy developments, an overview of NPHI's policy priorities in the legislative, regulatory, and CMI arenas, describing to you how you can engage with our public policy priorities and agenda through member engagement opportunities, and finally, a Q&A where we will field your questions and respond to your feedback. So with that said, I'd like to turn it over to Ray to provide an outlook on the 2020 elections and their impact on NPHI's public policy agenda.
Thank you, Svetomir. As we all know, we just completed an election. Well, it's almost over. And it's a clear example where policy intersects politics. NPHI was right at the center, as always, advocating as well as shaping policy alongside as well as on behalf of all of you, our members. And this is an example of how we got here. These are all issues that were on voters' minds when they cast their ballots, and they continue to be on voters. They continue to be on our minds in terms of what it's going to look like and what the political landscape will continue to look like. The economy is a highly important issue. The public health emergency is one that we can't forget, nor should we, dealing with COVID as well as the response. Issues related to racism, protest, as well as health equity continue to remain important. Everyone is so concerned about unemployment, as we should be as a country. There was a Supreme Court vacancy, and now there's been a Supreme Court appointment. And now we're waiting for a peaceful transition of power. And on the next slide, we talk about the pre-election healthcare landscape. What were the issues? There were three key areas. The COVID response for one. Secondly, legislative as well as regulatory, regular order. And third, administration advancing their agenda. COVID-19 funding as well as COVID-19 flexibilities. They were part of unprecedented changes and unprecedented work by Congress as well as the administration in order to respond to a public health emergency, ensuring and working toward providing PPE for you, our first responders, those on the front lines in order to provide patient care, as well as the payroll protection program in order to ensure that our programs could remain vital and could remain in their communities to support patient care. And ensuring that there were flexibilities on the regulatory front so that you could provide the appropriate care and you can continue to provide the appropriate care throughout the public health emergency. Now, we're not going to say it's been perfect. The policies have not been perfect. However, we continue to advocate on your behalf to improve these policies for the remainder of the public health emergency and beyond. There will be lessons learned, including on telehealth flexibilities, which we'll talk a bit more about later. And now there continues to be work to advance a COVID-19 vaccine, to ensure that it's available, to ensure that it's safe, and to ensure that the American public is educated about the importance of a vaccine. Moving on to the Medicare extenders. These extenders are going to be part of an end-of-year package. As always, Congress is working toward a deadline. There's an expiring continuing resolution. This continuing resolution is not just any resolution, it's a resolution that will keep the government funded. It's a resolution that will ensure that the government does not shut down and can continue to fund important programs like Medicare, Medicaid, Social Security. There are also primary care payment models that continue to are working toward implementation. NPHI was there from the very beginning, having conversations, advocating, and shaping again primary care first, direct contracting. There's been a lot of work done in the rural health space. In rural health, the administration passed an executive order to help improve care in rural communities via telehealth and otherwise. The administration has also worked through executive orders to address issues such as the rising cost of drugs, surprise billing, and coverage of pre-existing conditions. And a lot of this work for pre-existing conditions is trying to mitigate any impact of changes to the Affordable Care Act dependent upon what the Supreme Court decides. Now, the next slide talks about, well, what do these results as of today mean? Today, we're presuming, just as all the networks have, just as most people have, is that Vice President Biden, as well as Senator Harris, will win and will then become President Biden and Vice President Harris. What will they be dealing with? An issue that shaped the campaign, but more importantly, an issue that has been life-changing, has been life-threatening, and has actually killed many. They inherited a COVID-19 crisis. We are all very aware of it, painfully aware of it, whether it's from a policy standpoint or a patient care and a grief standpoint. They will now have to manage this, and there will be challenges managing it, related to the vaccine, related to distribution, yet that's going to be an important policy platform that they will have to continue to move forward because it was such a big part of the campaign, and it's such a big part of what we are all experiencing today as the United States. The second area is going to be an area where they can build upon the Affordable Care Act. That was a big part of the Obama administration, which former Vice President Biden was clearly a part of. But it also opens up a field for broader role of government. What will this mean? It means that the progressive side of the Democratic Party will likely try to advance reforms like Medicare for all or a single payer system. Now, let's keep in mind that during the Democratic debates, which seems so long ago when we think back, Vice President Biden, now President-elect Biden, he still felt that there was a place in the healthcare system for private insurers and continues to believe so. So whether or not the progressive wing of the Democratic Party will prevail is unclear, but he has staked his position at this point. And importantly, continued work will need to be done on lowering the cost of prescription drugs. This administration currently has a very tenuous relationship with drug manufacturers. The administration has worked through executive orders, as I mentioned earlier, to try to change and try to curtail drug pricing. It'll be a question as to whether newly President Biden, as well as Vice President Harris, will work closely and carefully with drug manufacturers to find solutions to still lower drug prices, but to find compromise and work together. And the next area is an area that President-elect Biden is no stranger to, unfortunately. He's no stranger to loss. He's no stranger to grief. It's an area related to caregivers in home care and support for long-term services and supports, LTSS. It's an area that caregivers were a specific part of his platform in his campaign for president, and we anticipate will be a big part of his healthcare agenda, regardless of who he names as Secretary of the Department of Health and Human Services. This also provides an opportunity for NPHI to continue the work that we have to support caregivers, but also to broaden that platform of the president to focus on hospice care, palliative care, and advanced illness. And the next slide continue on the results of today. We still have a House and a Senate to deal with. The House still maintains a Democratic majority. However, they had a decrease in their number of seats, which came very unexpectedly. There will be some changes in the committee's structure based upon the change in the majority, the number of majority. However, what this means more importantly is that the Democrats may rethink their strategy moving into the midterm election, which it's amazing to think that we just completed an election and we're already thinking about the next election, which is 2 short years away. Now, with that said, the Senate is looking a lot different. The Senate, we don't know who's in the majority at this point. The control is still up in the air. However, it will likely become, or remain, I should say, Republican. And the reason for that is because there are 2 races that remain outstanding, and they will be determined on December 5th in a runoff election, both of which will occur in the state of Georgia. And what's important here is that the control of the Senate is going to remain Republican, and if it does, there will still be a divided government. And that divided government means that we need to continue to work across both sides of the aisle and across both sides of the Capitol. And on the next slide, we continue with that divided government, where the Biden administration will need to continue and will need to begin compromising not only with House Democrats, but more importantly with Senate Republicans to all work together in order to advance any policies. And in addition, President Biden already has a track record from his time as vice president working with Majority Leader McConnell. And that should bode well for the two leaders if they choose to work together. However, it's unclear whether they will, but we remain hopeful that they will in order to advance their mutual priorities and priorities of NPHI. In the meantime, we continue waiting for the official results of the Electoral College. And in the meantime, there's a lame duck session. And this lame duck president, what that means is that there's still an opportunity for policy making to occur. And that policy making could be important policy that is impactful related to Medicaid and also related to reshaping and or changing the public health system and the agencies that are charged with overseeing public health. And again, going back to deadlines, Congress is working towards that December 11th funding deadline, and that pressure is on. But we are also applying pressure to ensure that our legislative priorities are included in that spending bill that needs to be passed by December 11th, which we'll talk about shortly when Svetomir provides you information on our legislative priorities. So now I'll hand it over to Svetomir to talk about our 2020 key policy developments.
Thank you, Ray. And so I'd like to start off by providing the members with a recap of the key 2020 policy developments. But before I do that, I'd like to introduce everyone to the newest member of the NPHI policy team, Ethan McChesney. Ethan is our Policy and Innovations Associate, and so that means he'll be working both on the innovation lab work and on our NPHI's policy and advocacy work as well. So we're really grateful to have Ethan join our team, and we look forward to having you all interact with him as well. With that said, on the next slide, in terms of the key 2020 policy developments, there are largely two buckets of big policies here. The first being those related to COVID-19, the second being those independent of COVID-19. As you all know, the pandemic has put such an immense strain on the healthcare system that as a result, Congress, the administration, and the industry as a whole has pushed forward a set of reforms that would normally take years to develop and implement. But now in the span of months, we have seen such an uptake of new policies and new models of care, such as expanded use of telehealth, that this has been such a big policy experiment in and of itself. Meanwhile, the administration and Congress also continue to make and implement reforms irrespective of the pandemic. And these are reforms that have been in the process and in the making for many months and years to come in some cases. So on the next slide, the big topic on everyone's mind related to COVID-19 is the expansion of telehealth. Very early on in the public health emergency period, Congress and the administration acted quickly to expand access to telehealth to make sure that patients, beneficiaries both have continued access to see their medical providers and to reduce the amount of in-person contact that happens to ultimately stop the spread of COVID-19. Specifically for hospice providers, CMS and Congress provided two different forms of telehealth flexibilities. The first being the ability to deliver routine home care via telehealth, and this was done through CMS's authority under Section 1135 of the Social Security Act, which CMS uses during moments of national emergency. Additionally, Congress passed the CARES Act, through which it allowed hospice providers to recertify patient eligibility through telehealth. Both of these telehealth flexibilities came at a crucial time and were developed over many years of advocacy, especially from NPHI. It actually was one of our main policy priorities to allow for patient recertification via telehealth to help reduce the administrative burden of the process itself. So we were pleased to see that it was included in the CARES Act, and we look forward to helping shape its permanency moving forward. Now on the next slide, continue the theme of COVID-19. The other big changes as a result of COVID-19 include the suspension of the Medicare sequester that's currently set to expire on December 31st, 2020. And one thing I do want to point out that this is ultimately a delay of the sequestration, of the total sequestration, because Congress only pushed back the ultimate timeline for it by 1 year. So sequestration was originally set to end in 2029, but now we will see it end in 2030. There's also the Provider Relief Fund, which was made possible through appropriations from Congress to HHS to the tune of $175 billion. The funds were initially distributed automatically, but now providers, including hospice providers, must actively apply for them. As we'll discuss later, HHS has recently released a set of reporting requirements that have made it potentially more difficult for providers to use this fund. As Ray mentioned, it's really difficult to get these kinds of emergency priorities right the first time. So we've been working with the administration to make sure that their reporting requirements are revised and ultimately responsive to the needs of our members. And so that ultimately you can all use the full amount of relief funds that have been given to you without the possibility of having to return them. And there's also the temporary suspension of medical reviews. This is once again authorized under Section 1135 from CMS. And unfortunately, the suspension of the medical reviews ended in early August of this year. So now it is one of our main and top priorities, both on the legislative and regulatory front, to make sure that these medical reviews are paused, especially as the COVID caseload across the country reaches 140,000 cases per day or higher as we go on. So on the next slide, there's also the set of policies that have come out regardless of COVID-19, but certainly been impacted by it. So the first one, as many of you I'm sure are aware by now, is the October 1, 2020 launch date of the requirement for all hospice providers to provide an addendum statement to patients or the representative if they request it. And this addendum statement lists out a hospice's termination of both related and unrelated services. Now, we at NPHI, along with other stakeholders, called for CMS to repeatedly for CMS to delay the implementation of this requirement as of October 1, 2020, but unfortunately they chose to go ahead with this implementation deadline. And so we've been working closely with a work group of NPHI member staff on the implementation of this requirement and providing feedback and guidance on it, but that's more to come on that later. There's also the announcement of the VBID carbon, hospice carbon participants and subsequent guidance released by CMS. As announced last month, there will be 9 plans that will participate in the carbon demonstration across a total of 13 states and Puerto Rico. With that said, not every county in each state will be part of the service area of the plans, but there are indeed a number of NPHI members who are actually in the service area of these plans. And so this initial rollout with the 9 plans in 13 states was rather limited, but that was generally the expectation of the rollout of the carbon, as plans will want to take a measured approach to this. And we think that's generally the right direction, since this demonstration is ultimately a test of the hospice carbon. And we want to make sure that it's ultimately rolled out in a timely fashion that can allow for working out certain technical details and operational details so that patients and beneficiaries are ultimately served best by this demonstration. After CMS announced the carbon participants, it also released additional technical and operational guidance with significant input from NPHI. And so this guidance covered topics such as billing and coding, how to identify a patient that's part of a carbon plan, and appeals and grievances. And so we really worked diligently with CMI to provide input to ultimately make sure that our members are best positioned for success in the model, along with the patients and families that they serve.
Svedimir, we should add that that's only one example in terms of the work that we've been doing with our members to receive information directly from each of you in order to provide that to CMMI, but also to work across CMS on all of these policies. As we both mentioned, they've been moving so quickly, not specifically on the VBID carbon, because we've known that that's been coming, we've been working with them, but on the COVID-related policies, they've been moving so quickly. We've been working with legislators on Capitol Hill on a daily basis, as well as regulators, to ensure that if they don't get the policy right the first time, that they will move toward getting the policies right. And not only for large programs, but also for small programs, that everyone should be given opportunities, whether it's for PPE or whatever it may be. We continue to be the voice for all of our programs, and hearing from each of you helps us continue to do so and to advocate on your behalf.
Yes, thank you, Ray. And on the next slide, I want to now transition over into an overview of NPHI's policy priorities moving forward, how we got to those priorities and the path forward. So just as a quick background, these policy priorities come from, for the coming year, stem from our past advocacy efforts on the Hill and with the administration. Based on our members' past feedback, we've also incorporated your current feedback during the COVID-19 pandemic based on the new telehealth flexibilities, for example. And we've also made a number of refinements to our own internal thinking on how to further flesh these policies out. And so with that said, there are three key areas for that we are focusing on: the legislative front, the regulatory front, and engagement with CMMI. Additionally, we've tried to delineate these policies by both short-term and long-term priorities as well. So on the next slide, our immediate priorities here are obviously to address the impact of COVID-19 on our community-based not-for-profit programs. So what this means from a legislative perspective is making sure that our programs have continued access to PPE, testing, and improved COVID-19 treatments. This also means extending the suspension of the Medicare sequester beyond the December 31st, 2020 expiration. This also means extending the suspension of medical reviews from MACs and other audit entities. And as you'll note, this particular point here is captured in both our legislative priority and our regulatory priority for COVID-19. I'll mention more on why on that later. And there's also our priority is to expand access to respite care during the pandemic to make sure that patients and their families can receive respite care outside of an inpatient setting and for longer, so that ultimately this care can be provided at home. And finally, securing additional funding for expanded grief and bereavement counseling, because as you all know, COVID-19 has fundamentally offered how individuals in this country can process grief and observe traditions that respect the passing of someone. And so we think our members who have so much experience with this and offer such an expanded access to grief and bereavement in their local communities, and not just to the people on their service, are well positioned to offer this expanded kind of care to anyone who's been impacted by COVID-19. From a regulatory perspective, we're also working to make sure that once the administration does have the access to additional PPE and funding for all these resources, that they are prioritizing our community-based programs in access to PPE testing, COVID-19 treatments, and an eventual vaccine. As I'm sure you've all heard by now, HHS has gone forward and distributed COVID-19 tests to the 100 largest home health and hospice providers. And we're certainly happy to hear that HHS is supportive of the hospice community, but ultimately we think that this distribution could be better done by instead prioritizing smaller community-based programs, such as some of our members, because ultimately larger programs, hospice programs, already have access to the economic and buying power leverage to get access to these tests. Instead, the most amount of impact can be found by distributing directly to smaller community-based programs. So that's why we are currently discussing at the highest levels with HHS how to distribute, priority distribute these tests and PPE supplies, and additionally engage the Biden transition team to make sure that they're aware of our priorities moving forward. As I mentioned before, suspending medical reviews is both a legislative and regulatory priority of ours. CMS, through its own authority under Section 1135, was able to suspend the medical reviews, but as of early August, they resumed them. And so we are currently working with CMS to once again make sure that they understand why it is so important to suspend these medical reviews, as each of our member programs work on a daily basis to handle the new COVID cases, and instead you are all receiving new audits or the restart of old audits that have been in the process already, and diverting staff time away from caring for COVID patients to processing these audits. So we are currently trying to work with CMS on using their own authority to pause these medical reviews, but ultimately we will look to engage Congress on this issue as well to make sure that if CMS does not act, that Congress can act on our behalf instead. And finally, our last priority is to continue to make amendments and changes to the Provider Relief Fund reporting requirements. As I mentioned earlier, when HHS first released their reporting requirements, they were very prescriptive in how they defined lost revenue for the purposes of using the additional funds from the relief fund. And so with this very prescriptive definition, there was a high risk that many of our programs would have to return additional funds. Additionally, they were also very prescriptive for how to measure the period of these decreased funds, decreased revenue rather. So how exactly does one go about measuring the time period for this decreased revenue? Thankfully, HHS has instead moved away from its past definition of decreased revenue to a more broad definition that's beneficial to our programs. But the very prescriptive time frame still remains, and we are working with HHS to make sure that they go even further and provide more flexibility to the time frame to measuring decreased revenue, so that ultimately you all have access to the full amount of your relief funds attributed and appropriated to you. On the next slide, please. And here I'm going to go into our longer term legislative priorities. So it is our ultimate goal to reform and modernize the Medicare hospice benefit through a comprehensive legislative package. We also need and want to be ready and flexible to insert certain priorities into legislative vehicles as opportunities present themselves. So while we would like to have a comprehensive package, there's certainly open the option to insert certain provisions into whatever vehicles are moving at the time. Our legislative priorities also include a combination of COVID-19 related policies, such as permanency for certain telehealth flexibilities and other non-COVID-19 related policies. And as I mentioned before, these priorities are based on NPHI's legislative work, along with more recent feedback from you, the membership, and internal refinement. So on the next slide, I'd like to go into 3 of our highest priority issues for the long-term reform of the hospice benefit. The first is to apply what we're referring to as a special designation that recognizes the unique contributions of community-based non-for-profit programs. We've heard so often from you all about the level of investment that you provide within your communities with respect to the kinds of patients you see, and not turning away a patient because of their terminal diagnosis or because they're overly complex. Our members truly do see whoever comes into their front door and is referred to them on a daily basis, which unfortunately can't be said of all hospice programs. Additionally, we've heard from you all the unique level of access that you provide to your patients and families through your investments in all 4 levels of care. That includes not just routine home care, but also expanded access to GIP and respite care. And so with that said, we are currently looking at ways to recognize your unique efforts by creating a special designation based off of the level of complexity that your program, the patient level of complexity that your programs see, or through a measurement of the unique level of access to the 4 levels of care that our programs bring. So in the near future, there will be more opportunities for you all to engage in the development of these policies, and I'll mention more on that later. But right now, we are currently focused on applying the special designation based on either the complexity of the patients that our programs see and or how the unique level of access that you will provide to your patients and families. Moving on, we would like to see a phase-in of the reduction of the hospice aggregate cap, and additionally apply a wage index adjustment to the aggregate cap. So this follows recommendations from MedPAC that NPHI has supported in part based on the problems and issues that we see with hospices that tend to hit this aggregate cap over time. And so we believe that MedPAC's recommendation in general is a step in the right direction, but we would like to see a number of modifications made to that recommendation. Namely, we would want to phase in the reduction of the aggregate cap over time so that its impact on the industry is spread out and not just all at once. And additionally, to the wage index component of the recommendation, our number 1 priority for the wage index before it is applied in other policy areas is to amend the process for calculating the wage index in the first place. So as you see here in the 3rd portion of the slide, we want to amend the process for calculating the wage index so that ultimately there is what is known as a rural floor, so that no hospice program receives a wage index rate that's below the current rural rate within their state. We've heard from a number of you that when CMS calculates the wage index rate for your specific programs, that sometimes in specific counties, that wage index rate actually falls below the rates of nearby rural counties. And so the hospice wage index is actually based off of hospital cost data, and hospitals currently enjoy the benefit of a rural floor, but our hospice programs currently don't have that same protection. So ultimately, we want to make sure that the wage index is updated so that there's a rural floor. And so with that update, we would then like to apply the wage index adjustment to the aggregate cap. but only if and only there's a change to the wage index adjustment. I also want to point out that as MedPAC modeled, the impact of reducing the hospice aggregate cap almost entirely avoids impacting non-for-profit programs and instead targets those actors with poor behavior across the board. So on the next slide, I'd like to focus on our telehealth priorities legislatively. So our general priority here is to make permanent both telehealth flexibilities available during COVID-19, namely telehealth for routine home care and telehealth for the patient recertification process. So as part of a membership feedback process and member listening sessions that we conducted earlier in this year on how you would like to see telehealth move forward, here's what we've heard from you all. The first priority being that telehealth should ultimately supplement and not supplant high-touch, high-quality hospice care. Because ultimately, telehealth should be used to complement the kinds of high-quality care that our members provide and not serve to replace the kinds of in-person interactions that patients and families ultimately value the most at the end of the day. And so what we do want to see is telehealth expand the capacity of our programs to reach more members in their community and to more timely respond to emergent needs, or for example, reduce the amount of after-hours calls. What we would not like to see is instead have the hospice benefit become primarily a telehealth benefit with only visits being made over a camera via whatever video sharing platform program may use. And this would ultimately dilute the core philosophy and benefit of hospice care. With that said, there are still a couple of hurdles to overcome in making this permanent. The first being, how will visits actually be recorded in claims and quality measure data? So as you know, currently CMS does not allow hospice programs to record these telehealth visits in claims. And so ultimately there is no record to track them in the long term. Additionally, there's very little guidance for how quality measures will adapt to these new telehealth flexibilities. So this is two items that we're currently working through, and we actively encourage you all to send in your comments and feedback on these questions. Additionally, we will need to likely address concerns from Congress about fraud, waste, and abuse. As Howard mentioned earlier, there are a number of enforcement actions from OIG that are related to telehealth, fraud, waste, and abuse. And these concerns may continue after the OIG performs further investigation on the use of telehealth during the pandemic. So ultimately, we will need to overcome concerns from Congress about this. Additionally, for patient recertification, this has been a longstanding NPHI priority to reduce the burden of performing these recertifications, and we would like to see this made permanent. And ultimately, we will still need to address fraud, waste, and abuse concerns from Congress, but this is a vital component in the full suite of telehealth services that we think our hospice program should have moving forward. On the next slide, please. Now to review the remaining policy priorities. First, to call out the ability for NPs and PAs to bill Medicare outside of the context of attending physicians. So we've heard from you all a number of times that allowing NPs and PAs to bill separately outside of the benefit is crucial to maintaining patient access, especially during, for example, weekend visits or after-hour calls. So we are working to make sure that our hospice providers have access to the same kinds of NP and PA flexibility that other provider types have had over time. For example, home health services can now be authorized and provided by PAs and NPs as opposed to just MDs. So we want to make sure that hospice providers can continue to can benefit from this trend of moving towards PAs and NPs expanded scope of practice and billing. Second, the decline standard is still very much top of mind for us, and as Howard mentioned, we are looking at potential legal action against HHS on this issue. However, we still need to work towards ultimately a legislative fix for this, since the legal time frame for action is much more extended and could take years and years before an outcome is ultimately released. So we will be pursuing a dual track process here of both applying pressure from a legal perspective and working with Congress to apply pressure to HHS and CMS. We are also continuing our work on developing an audit enforcement mechanism to redistribute the burden of medical reviews. As we've discussed with you before, NPHI has been working with CMS to develop an algorithm of sorts that helps target CMS's audit enforcement activities towards hospice providers that have a history of questionable practices. And so we think this will better target HHS's efforts and CMS's efforts in the fraud, waste, and abuse categories, while also reducing burdens on our hospice providers and programs. We also want to create a reimbursement for the process of recertifying patient eligibility, as ultimately this is an unfunded administrative mandate, and this will help offset some of the costs of performing the recertification. We also want to make sure that we're continuously helping expand the workforce of serious and advanced illness providers. So we will be looking to create Medicare grants for the purposes of expanding the workforce by providing grants to hospice providers, for example, who provide additional education to different kinds of physicians in the community to specialize in palliative care, for example. And finally, we'd also like to expand the ability for PAs to perform the certification and recertification of terminal illness in the same vein as expanding the ability of hospice PAs and NPs to bill for expanded set of services. Next slide, please. So with that said, I'd like to pivot to our regulatory priorities moving forward. Our first priority here is to further modify the Provider Relief Fund reporting requirements. As I mentioned earlier, HHS did make an initial change to align their definition of revenue with a more common interpretation that ultimately will likely benefit our members. But they still have a very prescriptive measurement process for how to calculate lost revenue. So we would like to see this changed very quickly so that ultimately our providers can hold on to as much of the provider relief funds as possible and use them for purposes of addressing COVID-19. We will also be continuing to work with CMS, as I mentioned earlier, on the development of an audit enforcement mechanism that redistributes how CMS targets its audit enforcement activities. Additionally, we will be engaging with both CMS and CPI, the Center for Program Integrity, to demonstrate the burden of medical reviews on our programs. I just want to take a moment to stress the importance of the Medicare audit intake form that Howard mentioned in his presentation. As you all know, the Medicare audit intake form is used by NPHI to help track trends in audit activity over time and to help provide you with individual support as your programs receive these audits. In the future, we would like to use this audit intake form to ultimately gather more quantitative data from you on the burden of audits on your programs. And this kind of data could include, for example, the financial impact in terms of how much money CMS may have held up in the process of appealing a decision over the course of what is an average of 3 years. Additionally, the amount of staff time that your programs are forced to reinvest away from patient care and towards responding to these audits, and the kinds of vendors or outside counsel that you may employ and incur direct costs to ultimately respond to these audits. So I really would like to stress the importance of using the Medicare audit intake form currently so that we can track these trends, and in the future, as we work to collect more data from you so that we can build a strong quantitative case to prove to CMS and CPI just the scope and impact that these medical reviews have on our programs and ultimately patients and families. Next slide, please. And so here are some other regulatory priorities that are not necessarily related to COVID-19. As you're all aware, earlier this year, CMS launched Care Compare. Care Compare is the new CMS website that consolidates all the different versions of the current quality reporting programs, public-facing reporting. So that includes Hospice Compare, Nursing Home Compare, and the different hospital reporting programs. Earlier in the year, we also convened the Quality Improvement Forum to provide feedback on this new website and how it may impact the ability of patients, families, and providers to navigate this new website. And here's what we've heard from you all so far. The first item here is that it's difficult to navigate from both a patient and provider perspective. Oftentimes, patients will see the ability to scroll through 10 plus windows of different hospice providers in a certain county, and ultimately that is not helpful to be presented with over potentially 20 plus, 30 plus hospice programs to choose from. Additionally, the information uploaded to Hospice Compare or the new Care Compare website is not a timely amount of information in the sense that there's a significant amount of data lag. So when patients go to make their decisions about which hospice provider to use, they are often looking at data that is at least 1 year or 2 years old. And finally, CMS does currently include descriptions of why certain quality measures are significant or why patients should care about them. We think that's a great step forward, but sometimes the descriptions don't quite miss the mark and there's an inconsistency there. So we would ultimately like to work with you all to craft guidance and suggestions for CMS on how to better construct Care Compare moving forward. Earlier this year, we also convened the Regulatory and Compliance Work Group overall, and we first launched it this summer. As a result, an outshoot of that work group, we also convened a work group specifically focused on the new addendum statements. And there are still 2 sets of outstanding issues related to the addendum statements beyond their implementation. The first being how CMS exactly will audit these addendum statements and the process by which hospice providers will need to be compliant with them. So what exactly are CMS's expectations for providing timely addendum statements and documentation? That's currently unclear and poses a large uncertain risk to our programs. Second, CMS currently states that providing an addendum is a condition of payment, but provides very little detail about what that actually means. So ultimately, we would like to work with you all and CMS in tandem to make sure that these addendum statements do not negatively impact our programs, and so that CMS does not create guidance or a set of audit priorities and guidelines that ultimately are not responsive to what their current regulatory requirements for the addendum statement. We will also continue to engage CMS and NQF on the development of hospice quality measures. NPHI currently actively meets with NQF to guide the development of current hospice quality measures. And at the moment, CMS is considering changes to the measure pair that measures the visits in the last days of life. So we are in very active conversations right now with CMS on this issue. And finally, there's the development of the HOPE tool. As I'm sure you've all heard, the HOPE tool is currently in alpha testing per CMS's recent announcements of the alpha stage testing participants. And the timeline of the release of the HOPE tool is ultimately dependent on how quickly CMS can move through alpha and beta testing stages so that they can introduce a full tool in a proposed regulation. So we will be working closely with our members who are currently part of the alpha stage and potential participants in the beta stage to create feedback, comprehensive feedback for CMS on the HOPE tool, eventually leading to the public comment period. Next slide, please. Now moving on to CMMI. So first is the topic of the hospice carbon. So as Ray mentioned, we have been engaged with CMI on a number of fronts, and not just the carbon, but the direct contracting and PCF SIP. And through our engagements, we've built a very strong relationship with CMI staff over time, and we have come to form a very trusted relationship. And so on the topic of the hospice carbon, we will continue to work with CMI closely on its implementation as they release future guidance so that our members and your patients are ultimately positioned for success under the model. We would like the carbon to be a collaborative interaction and process between the participating plans, our members and hospice providers as a whole, and patients and families, so that ultimately we can meet the CMI's goals of increasing innovation and access to hospice care in the model, while decreasing any administrative burden for hospice providers. Internally, we will be working with you all across the board to provide additional education and guidance as the carbon evolves over time, and we will be providing individualized specific support to the members who are part of the service area of the carbon plans. On direct contracting, we are aware that a number of you are currently interested in participating or are already participating as part of the implementation period. So we are committed to supporting all members who are exploring the option to participate in the model, whether that be forming a direct contracting entity, becoming a participant provider, or becoming a preferred provider, and actively supporting members who are participants in the model in any way, shape, or form. On the topic of PCF and the SIP track, we are committed to working with CMI to further refine the model over time to ultimately be responsive to patient needs and the needs of the participants themselves. We are also aware certainly that a number of you have applied to join the PCF SIP track, and so we are committed to everyone who is interested in joining PCF-SIP down the road, or for those of you who are about to begin your participation in the upcoming performance year. And so this is just a sample of our overall engagement with CMI, and certainly it's not limited to these models as we work on expanding the scope of the populations that our hospice providers serve, and ultimately to leverage the interdisciplinary care model that our hospice providers employ. Next slide, please. And so I'd now like to go over a quick set of member engagement opportunities moving forward. Next slide. So as I've mentioned, all these issues, our regulatory, our work group and forum participants have been key in helping NPHI's regulatory and advocacy agenda and helping shape and provide feedback. So I'd like to thank everyone who has participated in any of these forums and work groups, as your feedback has been so crucial and your expertise has been incredibly helpful in guiding our policy priorities. And so with that said, as I mentioned, we launched the Regulatory and Compliance Work Group earlier this summer. And as you can imagine, it's focused on compliance and audit-related activity, including the implementation of the addendum statement. Separately, there's the Quality Improvement Forum, which is focused on our quality measure work and improvement-related activities. So that would include the launch of the Care Compare, the new quality measure specifications, and implementation of the addendum statement. There's also the CFO Forum, where we've heard from the CFOs about the impact of the Provider Relief Fund reporting requirements and understanding the differences between the terms and conditions of the Provider Relief Fund and the Paycheck Protection Program. Finally, I do want to highlight an upcoming opportunity, our NPHI's policy roundtables, which will be a cross-disciplinary opportunity for all of your staff and our member programs to help inform more specific development of NPHI's policy priorities. So this is just a sample of the way we've engaged your staff and the membership as a whole on our policy and advocacy efforts and issues. And so moving forward, I encourage you all to continue to use these forums and work groups as an opportunity to share information with one another and to help provide feedback to NPHI. I would also encourage you, if you have any questions at any point in time, to feel free to reach out to myself or any member of the NPHI policy team. Next slide, please. And just as two quick reminders, NPHI, we do release our weekly policy update videos. So please be sure to look at them every Friday when they come out. And if you have any questions or feedback or ideas about a particular policy mentioned in the video, please feel free to respond directly to that email. And finally, I just want to take one last moment to reinforce the importance of the Medicare audit intake forms, so that ultimately NPHI can respond to your audit and compliance needs, and so we can eventually develop a quantitative advocacy effort for CMS and the Center for Program Integrity. Next slide, please. So thank you, everyone. I'd like now to transition to a question and feedback portion of the presentation.